Good morning, everybody, and welcome to the Transform Hospital Group's webinar this morning, the future of the collaborative partnership between the NHS and independent providers in the West Midlands and the Greater Birmingham area. First of all, thank you Transform Hospital Group for hosting this webinar, and obviously thank you everybody who's attending, and most importantly, thank you to the panelists for agreeing to be involved in this morning's meeting. So, first of all, just the structure of the event this morning. So, we formatted the event so that the panelists will have a 5-minute opportunity to give an introductory statement. We will then lead into some questions around this issue, and then at the end of the event, hopefully we will have about 15 minutes for question and answers from attendees. So please, if you have any questions that come to you during this event, please put them in the chat box. I'll be picking them up at the end, and hopefully we can get some further questions then. So first of all, really just to kind of why we're here today. So the webinar comes at really an unprecedented time, an unprecedented moment for the country, particularly unprecedented moment for the NHS. As we've seen this week, there is a pressure that is not likely to recede anytime soon. So despite these systemic pressures caused by the pandemic, COVID-19 has also brought about a sense of community, spirit, and collaboration, which has perhaps most been seen in the health sector. Now, from the outset of this pandemic, the NHS entered into a historic partnership with the independent providers in order to deliver the capacity required to respond to COVID-19. This deal has enabled NHS providers to make the use of the capacity available at independent healthcare providers in an attempt to prevent the NHS from being overwhelmed by the number of cases and hospital admissions during this period. So while this nationwide initiative has benefited patients across the country, the West Midlands and Greater Birmingham area has been a fantastic example of collaboration being carried out effectively and efficiently. So the partnership in the West Midlands successfully prevented the NHS services from being overwhelmed, but it's also helped break down it's also helped break down barriers that have prevented such partnerships from taking place previously. So it's highlighted on a national and local scale that providers are willing to work together to bring about positive transformation to the benefit of patients. Most of all, it's highlighted that all healthcare providers, whether they're public or private, they do share one common goal: delivering outstanding patient outcomes. So that's the basis of where we are today. Obviously, we've got 3 great panelists today to really kind of further some of those thoughts and ideas and really look to the future and see how, see how this partnership can evolve and what potential barriers there might be in preventing that. So first of all, I'd like to introduce our panelists. So first of all, we have Tony Veverka. So Tony has been CEO of Transform Hospital Group since August 2017. Recently leading the company through its partnership with the NHS during the pandemic, which has seen both of Transform Hospital Group's hospitals support NHS patients in Birmingham and Manchester respectively. As the leader of an independent healthcare provider, Tony will provide first-hand perspective of the successes and the areas for improvement taken from the partnership during the pandemic, as well as sharing his vision for the future of the provision of healthcare across the UK, drawing particularly on Transform Hospital Group's experiences in the Greater Birmingham area. Now, we are also joined by David Furness, although I'm not sure David's just been able to join us just yet, but I know he'll be joining us any moment. So David is the Director of Policy at the Independent Healthcare Providers Network, which is the trade association representing independent healthcare providers. Now, IHPN works across all public policy issues that affect the sector, most recently coordinating the collaborative partnership between the NHS and independent providers in order to provide additional hospital capacity during COVID-19. David is responsible for IHPN's policy development, strategic influence, and delivery of care. David should be with here, so sorry if you heard that, it was just David letting us know that he should be with us any moment, which is excellent news. And last but most certainly not least is Ian Sharp. So Ian is the Medical Director of University Hospitals Birmingham NHS Trust and was appointed as BSOL system lead for the clinical side of the liaison with the independent sector at the very start of the pandemic in March earlier this year. As a result, Ian has been a key conduit in conversations between the NHS and independent providers in the West Midlands, overseeing one of the most efficient and productive partnerships across the country. Ian is a maxillofacial surgeon by trade with over 16 years of consultant experience. He'll be representing the NHS in this discussion and has experienced firsthand the benefits of collaboration between the independent sector and the NHS, and as well as some of the barriers that prevented such collaboration from taking place in the past. So thank you, panellists, for being here today, and I think attendees, you'll agree that we've got great opportunity here for a really valuable discussion about this issue. So, as I mentioned at the beginning, first of all, we're going to invite each of the panellists to make an introductory statement about where they are on these issues. So first of all, I'll turn to you, Tony, and if you could give us your thoughts about why we're here today.
Okay, thank you, Alan, and thank you for all the attendees wherever you may be. It is a Transform Hospital Group webinar, so I guess I should thank my fellow panelists as well, and everyone for contributing to what is going to be a lively discussion, I'm sure, for the next hour or so. It's actually a real pleasure to be involved in this sort of discussion because it's a really important area. I'm not usually one for webinars and the like, and I sort of generally keep my head down and get on with running the business and so on. But I think the times we're living in and the topic at hand for sure has really got me motivated to shout out a little more. And we've been doing a bit more of that lately at Transform Hospital Group in terms of making our voice heard in this arena, and particularly around this topic. Just for background, Transform Hospital Group is a leading provider of primarily cosmetic and bariatric surgery provisions, and indeed non-surgical cosmetic provisions. We operate hospitals in Birmingham and Manchester and a network of clinics across the country. But they are, in our core business, if you like, all self-pay services, not even insurance reimbursement for most actually. So the recent events around COVID and our involvement with the NHS, but both at the local and national level, is really a first for us, and these recent events have really seen us deliver a much wider range of services with the NHS and very quickly get up to speed in the sort of partnerships we have. So I think we've been really proud to play our part in the response to COVID-19 generally, and maybe we bring a sort of new kid on the block type of perspective to the issue of the public-private debate as far as provision of health is concerned. The title of the session obviously is about the collaboration and the partnership between the NHS and independents in the West Midlands. And to date, from our perspective, that's been a strong one for sure. I hope Ian would agree, and I sincerely hope that continues. But in a sense, I hope we go further today, because I think we've been in this discussion on really an essential topic for the healthcare industry more broadly, and indeed the country as a whole, because this is a critical moment, not just in the context of COVID-19 pandemic, but for the future provision of healthcare generally in the United Kingdom, I think, given the knock-on effects that the COVID pandemic has had on sort of normal services. We're sort of emerging from the first shock of COVID-19, whilst preparing for additional pressures in the winter months that you normally get with the NHS, and a potential second wave, all against a backdrop of actually what appear to be, from the outside, quite eye-watering waiting lists that have been built up as a result of routine elective surgery not having been performed over a number of months. And I suspect that's probably understated, if anything, given that less people have also been presenting in primary care in the first place, and so waiting was probably understated. So a really important and as Alan said, actually unprecedented time. I think at Transform Hospital Group, COVID has certainly opened our eyes to the importance of better collaboration across the system, and changed our business model very, very quickly. And I think, given where we are, that collaboration needs to continue probably more than ever before. And maybe I, get slightly irritated around the ideology that goes on around public good, private bad when it comes to healthcare. And it sure isn't the time for that. If we sort of hold to that mindset and place politics and ideology above public service, then we're doing patients a massive disservice. And I think in the current circumstances, actually in any circumstances, it really is, it's a matter of delivering the best public health service we can, irrespective of who the end provider of delivering the services actually is. So in a sense, that's some of the thinking, the broader thinking that's led us to convene this forum in the first place. But I have to confess to feeling a little like an audience member as well as a panelist, in that I probably have more questions than answers to the wider issues. Sure, we have an interesting perspective to share, being new kids on the block and all that, but you know, let's get real. We're a relatively small player in the whole healthcare ecosystem. And I'm sure, without putting additional pressure on my fellow panelists, I'm sure they'll be able to address some of the wider points and how we're able to move things forward in a sort of spirit of collaboration from their different positions, perhaps more effectively than I will. I think from our small parochial perspective, it may be worth sharing some of the recent months' learning. I think when it became evident that use of the independent sector capacity would be essential to the COVID response, we acted incredibly quickly. And I think as a member of IHPN, which, thank you, David, here for doing a great job with IHPN, and I'm sure you'll talk about that a bit more later, we immediately offered our services to the our NHS access to our hospitals in Birmingham and Manchester, as well as our clinic network, actually. And interestingly, we had and still have actually a strategy of providing broader healthcare services. But like many things, the COVID pandemic, whether it's telemedicine or automation of processes, the COVID pandemic sort of put that on warp speed in terms of accelerating something we were looking at getting in train anyway. In practical terms, we repurposed our facilities in a matter of days to support the NHS, whether that was additional ventilator capacity or hospital beds or medical professionals where they were needed most. And in the context of the West Midlands in particular, we're obviously thankful to Ian and his colleagues at the NHS for working with us effectively and enabling that collaboration to take place, I think and hope for the greater good. We also partnered to take recovering COVID patients in medical step down who would have ordinarily transferred to community hospitals. And once that had finished and we safely discharged those COVID patients, we sort of moved to a cold site to accommodate maybe NHS urgent and elective procedures that needed doing, including lots of cancer surgery. We did similar things in Manchester too, and so we went from being a sort of pure play, private pay, cosmetic and bariatric provider to delivering this broader range of services in a mixed economy, public-private model very, very quickly. But we're merely one example maybe of how the independent providers have demonstrated an ability to adapt efficiently and effectively and provide essential services and expertise when they're needed most. I'm sure David will probably have something to say about that, but it seems to me that the independent providers have really stepped up to the plate where they've needed to. And as we enter the next phase, it's really important that they continue to do so. We've got a long tail of waiting lists, and that's a long-term challenge, not just an immediate COVID challenge. So the adaptability, agility of the independent providers makes a compelling case for ongoing collaboration. So what of that future collaboration? As I've said before, I'm probably more of an audience member, but we see the collaboration between public and private providers really enhancing the patient journey. I think the pandemic has helped further develop those partnerships, and it's unlocked capacity and expertise where it's been needed, and it's broken down barriers. But I think we've also seen that the current model for delivery of care across the country has room for some improvement. And I think decentralization, more local decision making is really important here. I think, I know that was the intention originally of CCG groups and NHS Trust, but I think that can go further because more localized decision making, more decentralization plays to the strengths of the by both public and private providers where it's needed and where there are gaps in local provision. And that's one area, and I sense that feel that too, and maybe that's true elsewhere in the West Midlands as it is elsewhere. So I think that's the general thrust from me. I can see Alan's nodding as to get me off. I've got lots more to say. Sure.
Not at all. So there's some great points there, Tony, and I know that a lot of those points we will be picking up as we go through this event this morning. So I can't see that David. So next up is David. If you're there, if you would be.
Yeah, I'm here. I'm hoping that you can see and hear me, but
absolutely,
you know.
we can. Fantastic.
Okay,
so
good.
Dave,
It wouldn't be a webinar without a few technical difficulties.
Great. So it's great to see you, David. Thank you for joining us. And again, if you would be good enough to again give us an introductory statement and just give us your thoughts about where we are today.
Where we are, sure. Thank you. Well, thank you for having me, and thanks for the invitation, Tony. As Alan explained, I'm the Director of Policy at IHPN, with the Trade Association for Independent Sector Healthcare. And so obviously our interests are closely associated with kind of the role of the independent sector in the NHS and the way that we can work in partnership together. Over the COVID period, we've played a key role as an organisation in making the capacity of the private sector available to the NHS in a way that's just never been done before. We've seen over 8,000 hospital beds, over 30 mobile CT scanners, thousands of staff go into the NHS as part of that COVID response. And I think, you know, we're at a different place now in terms of the policy challenges we face. But I think one of the really important things not to lose sight of is that back in March, we really did think we might be facing a situation where the entire health system was going to be overwhelmed. And it was entirely right that we really saw providers drop everything, repurpose their business models, and do everything possible to support that NHS response and to enable the health system to respond properly. We're very proud of what's been achieved, and one important point to make is that all of that has been done at cost as well, so there hasn't been any kind of profit made from any of these arrangements. So I think just some important context there. But I think what we have seen is that you know, we've talked about the NHS response to COVID, and of course the NHS is the biggest and most significant part of the health system in this country. But what COVID has shown us is that what we've got is a healthcare system. We haven't just got the NHS, we've got a whole bunch of other providers as well, a whole bunch of other capabilities and capacity. I think, you know, we've always had this system, you know, ever since 1948, and indeed, of course, you know, general practice, a really key part of the NHS is actually in the private sector. It's lots of small independent businesses working with and as part of the NHS. But too often, as Tony alluded to, what we've seen is kind of an artificial divide between those two bits of the same system. I think we've assumed in policy terms that independent sector providers can only work with the NHS and as part of the NHS through competitive frameworks. So you'll all be aware of the 2012 Health and Social Care Act, which really did go further than ever before in embedding competition as the organising principle of the NHS. And it's always been assumed that the only way you can work with the independent sector is through competition. And so we've almost seen them as being synonymous. That you know, one of the big criticisms of the 2012 Act when it was going through Parliament was that it was about privatisation because it was about competition. Over recent times, what we've seen is competition, I think, fall out of favour as the organising principle of the NHS, because we've recognised the benefits of collaboration, we've recognised some of the limits of what competitive incentives can do to drive up performance. And of course, the severe financial pressure that the NHS has been under in recent years has made it ever more important to ensure that the public finances are managed sensibly, and that's obviously led to the emergence of first STPs and now ICSs as being the kind of the architecture of local NHS management. But I think COVID has conclusively shown that a competitive framework using public procurement or using patient choice or using tariffs and financial incentives is not the only way that the independent sector can work with the NHS, and that actually it's possible to forge genuine partnerships that are built out of, at their heart, arrangements between local clinical teams and team working between different organisations. And I think that's just a really important learning point that we need to drive forward. That doesn't mean that things like the commercial realities don't matter, because of course they do. And actually we know that independent sector providers do need to be able to invest, they need to be able to train and pay their staff. So we can't ignore that. But what it does mean is that we've shown that competitive framework that's been there to date isn't the only way that we can do this. So where are we today? Well, I think the obvious point is that we need as much capacity as we can get in the NHS. Our analysis suggests that waiting lists could hit 10 million by the end of the year, and that's not a kind of inflated or sort of scaremongering set of figures. That really is the impact of what we've seen in terms of the reduction of elective capacity over recent months. It was rightly essentially paused across the NHS. It's taken some time to build activity back up, and we know that in some places changes that we've needed to make in operational terms to manage COVID and make sure that environments are COVID safe are adding time, they're adding cost to elective procedures, which means that our level of productivity as a system may not be as high as it was. So we need as much capacity as we can get. And rightly, the NHS has recognised that. They're creating a new framework nationally, which could see a big increase in the amount of private sector capacity that's made available to the NHS. And we hope as well that will also provide a framework for investment, because I think that's a really important point, that, you know, the sector doesn't stand still, it isn't static. We need to make that possible too. But I think there are kind of two questions that I'd like to explore the next few minutes, or in conversation with everybody on the webinar. And the first is, how do we make independent sector providers a real and significant part of integrated care systems? I don't think we've come up with an answer to that yet. We know that there are governance challenges in integrated care systems anyway, because they don't, of course, exist in statutory form. But I don't think we've quite cracked the nut of how independent sector providers can play a role in systems that really were set up initially as a way of bringing NHS providers and commissioners closer together. And I think the same is true for voluntary sector providers, for social enterprises, and for local governments as well. We've seen people in some places really willing to try and make those partnerships work, but we haven't quite got the structures right, and I think we need to think that through. And the second point is that, as I said, collaboration is replacing competition as the organising principle of the NHS. But I think it's really important that we don't chuck the baby out with the bathwater here. And there are just 2 points I'll close with, Alan. One is to say that we continue to think that there is a role for activity-based payments, which help provide the right incentive structures to drive elective productivity and capacity. And we know that that's been the case. One of the problems with tariff and payment by results over recent times has been that it hasn't allowed commissioners to kind of keep a lid on activity levels and obviously then keep within budget. But, you know, with a waiting list of 10 million, we need to actually be realistic and say we need to incentivize providers in the NHS and in the independent sector to be as efficient and productive as we possibly can, and to prioritise the patients that are on those lists. So we think activity-based payments shouldn't be forgotten about just because we're looking at different ways to collaborate between providers. And the last point is patient choice. So patients have had choices guaranteed through the NHS constitution. That's been a route through which many patients have got to independent sector providers for their diagnosis and their treatment in recent times. There is a bit of a sense when you hear people talking about ICSs that patient choice is somehow yesterday's news. I personally don't think that that's the right approach. I think actually what we should be doing is empowering patients to make the right decisions for them about their treatment, and that includes deciding where they would like to be treated. We need to give patients good information, but I think it would fundamentally be the wrong move for the future of the NHS to be one in which patients have less choice than they have today, because I think that's just not the way the world is going. And I'll close there. Thanks, Alan.
Thank you, David. That's fascinating stuff there. And again, some points I know that we'll be touching upon as we move through this event this morning. So, Ian, so you're currently muted, but hopefully you'll be excellent. So, Ian, if you would, as again, last but not least, if you could just give us some introductory remarks, please, to lead us into this event.
Thanks, Alan. Yeah, I mean, it's been really interesting actually listening to Tony and David, and I'm sure like many people on the group, I've made notes as we've been going along. A lot of what I've heard I agree with, some of it I don't agree with. What I think might be useful would be to just, or when we did the briefing previously, what I suggested might be useful would be to just give a headline of how it has been really for the NHS in Birmingham, the Greater Birmingham and Solihull area, which clearly is where I'm coming from. And I recognise that's a very specific position and very different to many other systems and many other NHS engagements across the country. So just some context on that. UHB is my organisation, and as an organisation, we saw, and sadly it seems we are starting to see again, a very significant impact from COVID. So as Tony said, the threat of the NHS becoming just completely swamped with COVID patients was very real for us. And of course, it happened very quickly. And so credit where it's due, in those first early days of this NHS private or independent sector collaboration, one of the things that was most useful was to be able to genuinely just open a conversation with colleagues who are on this call and say, look, we're in real problem here. Can you lend us some ventilators? And the answer was universally pretty much, yes. How many do you want and when do you want them? And I think I've reflected on what was good about the relationship and what wasn't. And I'll come to that in a moment. But to be able to actually unlock that resource so quickly was hugely valuable to us in UHB and across BSOL as a system. And of course, we also had to unlock our own internal resource by taking down elective care, as David has described. And the impact of that, no doubt, we'll come on to talk to further. But everybody had to learn very quickly within the NHS and within our organisation that actually you can do other things than you would normally do. So we had a ward 412 as it happens, which was staffed pretty much by a group of surgeons, but was hosting medical COVID patients. All of the surgical staff did retraining very quickly in those first early days and weeks of COVID. And we very rapidly redeployed huge elements of our workforce internally within the NHS. And I'm sure that's true across the country. So not only did we have to learn how to work differently internally, but we also, as David has said, we had to start to learn how to work differently externally. And with the independent sector providers, you guys also all had to learn to work differently. And all of that happened very, very quickly. So when I reflect on what made that possible, I think there are a few key points. The first is the embattled spirit, if you like. I don't know what it is, whatever we call it, but the fact that we had one common enemy, which was very clear. It was absolutely clear that none of us were going to be able to do what we would normally do for an unknown period of time. And so we had the total resource of the NHS and the independent sector targeted on helping to deal with COVID. Now that is a unique opportunity. And I think that unlocked a lot of goodwill. I agree with Tony's comments earlier. Everybody was very focused on the matter at hand, which was dealing with COVID. So that was really significant to have that one purpose. The second point that I think David has talked about, and I've no doubt is very well known to many people on the call, was we did not have the commercial or contractual mess. I'm going to use that word deliberately because that, in my experience, is often what happens. We get so lost in the detail of trying to make a decision about moving some care or some quantum of work that actually we delay our ability to do it. Well, of course, in these times, we didn't have that. And clearly that's a benefit of having the very high level national negotiation carried out by David and colleagues with, no doubt, DH and Treasury behind them to just say, don't worry about the money, just make it happen. Now, of course, that's not real. That's not a real situation, and will be interesting to see what Rishi Sunak has to say today. But again, you know, we are just printing cash, aren't we? And that's not something that we can continue to do forever, and everybody is aware of that. But it definitely was really critical in unlocking the abilities of the NHS internally and our relationship with independent sector partners. But on its own, I don't think either of those things would have worked without the willingness of the relevant leads for each of the different sites. And for me, in BSOL, that meant working with people. I mean, I don't have any private practice. I never have had. So this was all completely new to me. So I was on a call. You know, we had Sylvie Adams put forward as the lead for BSOL to engage with us from Spire. We had colleagues on that call from all of the local providers. So we're talking to Circle, we're talking to BMI, we're talking to Spire, 2 sites, we're talking to Ramsey, Westbourne, Spa Medica. I'm sorry if I've missed anybody, but it was a long list. And we did that very quickly. And we actually got people around a table virtually on a weekly basis in a very open and very collaborative environment. And I think that is critical. The way that people approached the discussions about how we make this work was really important. So some of it was about purpose, some of it was about unlocking the commercial side of things. But the third thing, I think, is actually the behavioural stuff that people brought to the table, which really helped us. And we have delivered in BSOL a huge number of cases that otherwise would not have been treated. You know, and it's been a fantastic success. So credit where it is due to all of the colleagues on the call and others who aren't on the call. You know, yes, I was integral to it, but internally I had lots of people helping me out, and externally, without the response that we saw from all of our independent sector colleagues, this just wouldn't have happened. So credit where it's due. I think what matters now, and this is why this call is really critical, what really matters is how do we capture the good stuff that we've done and try to keep some of that in what will have to be a more commercially focused environment. Clearly, it will have to be. But how do we make that work without just going back to the position of, you know, negotiations around, is it tariff plus 20 or is it tariff plus 10 or is it how many cases, et cetera, et cetera? Because of course the transactional costs involved in that are very significant. And I think that's the key. How do we keep the good stuff, but not lose sight of the fact that we just don't have a bottomless pit of money to go at? Because I think we have to have a long-term relationship. I agree with David. The number, the 10 million number is a new one for me today, but I know the position internally within UHB and across BSOL, and it is a very big problem. So yes, I would say we need to reach a point where we can expect to deliver a volume of work through the independent sector on an ongoing basis, or we will never catch up.
Thank you. That's really helpful. I know you mentioned in your opening statement there that, you know, there was lots you agreed with and some things that you didn't, and I'm sure we'll kind of eke out some of those things that you didn't, perhaps as we go through some of these questions that we're going to look at first and foremost, first up. So I'm just going to start with the first question, and I will invite kind of different panelists to respond. If you'd be good enough, you know, if you'd be good enough to give us, you know, a couple of minutes of your response or thereabouts, or if you feel it was more relevant to another panelist, and please say. So I guess the first question is, you know, how can the independent sector's capacity and expertise be best used to address the backlog of patients waiting for routine elective surgery within the West Midlands area? And I know, you know, we've literally, Ian's literally just kind of finished talking about the waiting list, but I mean, I'll direct this first of all to David. So first of all, David, you know, what are your thoughts on that in terms of, you know, how the independent sector can address this backlog of you know, routine elective surgery?
I think there's a lot to go on there, and I think, you know, I know there are lots of operators on the webinar who have a view, but I think from our perspective, what we need is a few kind of foundation stones. So Ian's made some good points there. What we need is a kind of sensible, sustainable, reasonable commercial arrangement that provides some predictability and some certainty for both the NHS and for independent providers. So without that, it's going to be very difficult. And we need that, I think, to be based on a proper understanding of the COVID positive operating environment. And I completely agree that what we want to get away from is kind of wrangling between lots of different organisations about the precise kind of commercial terms for doing this kind of work. So in that sense, we welcome the new framework that's being created, although we are aware that there are lots of very successful contracts in place at the moment between different organisations, and we need to be very, very careful that what we don't do is just destabilise stuff that's working pretty well in pursuit of a big national solution, because we know that sometimes those big national programs have certainly some teething problems. So what we need is that, I think as well, what we need to do is make sure that independent providers have a kind of direct line from patients to capacity. And kind of what I mean by that is that I think there's rightly an effort across NHS systems to look at the to look at planning capacity and matching that with demand more effectively than we've done to date, and essentially making sure we've got proper clinical prioritization across different areas. I am concerned that if that becomes a kind of single patient list for all specialties and all providers in a given area, then what you will end up with is more bureaucracy, not less. And I think you will then find that independent providers, who are typically, of course, much smaller than a big NHS trust like the one where Ian works, will find that they'll kind of be allocated patients in a way that doesn't actually necessarily mean that they will be treated in the most efficient way. So you might end up with a different specialty mix from the one that will actually allow you to increase your throughput and productivity the most. You might end up with stuff coming at you too late, so you're not able to plan properly. And so I think we do need to make sure that what we come up with are kind of operational protocols that really do recognise the conditions that independent sector providers work in order to deliver the maximum capacity benefit.
And Tony, I guess from a transform perspective, as you say, you're a bit of you feel like a new kid on the block into this kind of scenario that the independent providers have found themselves in the last few months. So from your perspective, what role, how can the sector, the capacity and expertise be used, and again from a transform perspective to help this, to help bring down the waiting list for routine elective surgery. Well, Tony, I think we're on mute. Tony, thank you.
Okay, got me now. Yeah, I think that the collaboration with the NHS and providing services across the board, and I agree with what Ian was saying about one common enemy, and we all went for that. Actually, brought some real benefits to Transform Hospital Group beyond the commercial arrangements, in terms of just sense of purpose and vocation. And really some important things around morale of the business and being part of a wider effort to so we want to, I think we simply in an organisation, we'd want to keep that going forward. How do we do that? I agree with Ian actually. How do we do that when commercial realities more come into play? Because we're a smaller provider, maybe we have some limited capacity. Once we start bringing our own core capacity back of cosmetic surgery and bariatric surgery, and start filling that, how do we still provide services to the NHS which doesn't impinge on our ability as a commercial organisation and our responsibility to shareholders generally there? Getting that balance right is really important. But clearly we want to play a part. I think the point David made around getting the mix right of what you're asking independent providers to do, where there's a good fit, can really play an important part here. For instance, I mean, I guess one of our core modalities and core specialities is bariatric surgery, and we have huge amounts of expertise and lots of capacity to provide in that area, where maybe a number of NHS trusts maybe don't quite have that sort of focus and fix on something like that modality. And if we can take some of that off the NHS's activity list, if you like, to allow them to concentrate on something, then that's an interesting area where you can use our skills better to provide services for actually what's another major healthcare problem of ours, which we hear about, which is linked to COVID and obesity and so on. That's another major healthcare crisis we have coming down the path generally. And I think we can help there. So getting the balance right between the utilisation of our capacity whilst making in a commercial world is the key question. And I think, as I said earlier, I'm not sure that I have all the answers. I've still got lots of questions around this. But I think David and Ian are probably making similar points on that respect.
And obviously this is, this kind of touches upon some of the points that you were making in your introductory statement, but from your perspective, just to warn that you do have your mute on there. So I mean, from your perspective, we've already recognised the kind of capacity and the expertise, and you've already highlighted where you see some of the challenges. But if you could just kind of expand on that. We talked about the David mentioned this this 10 million potential 10 million waiting list, and you talked about your own waiting list in Birmingham in the West Midlands. So how can the independent sector, how can its capacity and expertise support this, trying to bring down the waiting list for routine and elective surgery in the region?
I think there's lots of different ways that the independent sector can help to do that. I agree with Tony's point that certain providers have certain strengths, and it would make sense, I think, to where we can to make the best use of the strengths of independent sector organisations. Now, I think we've done that to some extent, where we've managed to devolve a whole service, for example. That's worked really well. We managed to do that with Spire and Little Aston with our breast service. We put all of the surgery in one place and just drove it really hard. And of course, if you do that, you get efficiencies. And we've seen that happen, and that's been a great success. And I think doing that makes sense to me in terms of efficiency. Whether that makes sense to the independent sector provider or not, I guess it depends on how the contract turns out, doesn't it? And that's where we cannot get away from this. That locally, I would have a view of what my system can do, and it's my system is obviously you take that hopefully in the way it was intended, but driving it in a local BSOL way, I think we would choose to do things in a particular way, but we come up against the issues of commercial interest, yes, but more importantly, actually, about the governance issues and the national directives, which have now, they put in place a mandated different structure for example, preoperative screening. So I have a system-wide prioritization document. We have a system-wide preoperative screening, pretty much, process. We have an access policy, which is agreed across the whole of the BSOL system. So that's not just UHB, that's ROH and the Women's Hospital and the Children's Hospital. But then when we push a volume of work to BMI, obviously BMI have to work with their national directives, because you're a national sovereign organisation. Same for Ramsey, the same for Spire. So I think there is this, and there's going to be a friction between what do I think would work best locally and what does the national directive put in place, and we have to somehow find our way through that. So it's about efficiency, trying to play to providers' strengths. I think that's really important. And I think we can do that. I don't actually think that's that difficult, Alan, to actually work through that, as long as we continue to work in the way that we have. What we probably do need to do some work on is finding that sweet spot between local needs and national imperatives and drivers.
And so on that point, David, with your, so I wonder if you could respond to that with obviously your kind of wider national visibility of this. I mean, what's your thoughts on Ian's comments there about this, kind of local versus national issue?
It's a tricky one, isn't it, Alan? I think so we've got a contract in place that's going to run until the end of the year that covers kind of all providers from a national level, and I think frankly it's something that the NHS finds hard, because it is hard, is to get the balance right between national consistency and local determination, and I don't think there's a simple solution to that. So I'd probably almost revert back to something that sounds a bit trite, but isn't meant to be, that actually it's about establishing good, positive, local, trusting relationships, and actually then letting people get on with it as far as we can. I think that too often kind of national programs in the NHS end up being about prescribing to the nth degree what local organisations ought to be doing, and I know that because I used to work in national NHS organisations, so I've been some of the people responsible for trying to do some of that stuff. there is, I think, a genuine reason for that, which is that we have kind of national level accountability for the NHS. You know, this is still one of the only countries in the world where the Prime Minister will have to stand up in Parliament and talk about something that's happening in a hospital in any region of the country. That isn't normal, that level of kind of political involvement and oversight, and that means you end up with national with national leaders wanting to control things in a way that sometimes stifles local innovation. I hope that this new new framework agreement will give us that balance. We're working with NHS England very closely to look at the way in which it will be kind of operationalised locally, because it's all very well having a great national framework, but if it just doesn't work for the organisations on the ground, then it's not going to achieve what we want it to. So no easy answers, I'm afraid, there, but hopefully a way of thinking about it.
Thank you, David. We've kind of touched on that. One of the further questions we were going to look at was about this kind of local versus national, and and how, and I guess local versus central, and how that would work. So I wonder whether we perhaps look at just a different question at the moment, which I wanted to ask. I wanted to just put this to Tony, really, and about just from what we've experienced in the last 6 months, what key learnings can be taken from the NHS independent sector partnership, from this COVID-19?
So I think it's been said in different ways by perhaps all of us as panelists that the focus, the one single focus on dealing with COVID, created a set of circumstances where one, we really collaborated rather than conflicted and argued about the commercial realities, and everybody was really focused on defeating that enemy and supporting the greater good and so on and so forth. The other big thing for us, I think, that's the broader picture. The other big thing for us, I think, that it's really worked, albeit we had a national framework through that we got involved in terms of a national contract. Actually, the way this really worked effectively was in dealing with the local local NHS areas, trusts, CCGs, whatever, Ian and his team and so on. That's what really worked, where we were able to plan properly the modalities, the case mix, the meet the requirements of the local service, meet the requirements of the patient and so on. All of that really was just in local collaboration. And I think I'm not really going to answer or provide the answers. I've got more questions than answers, but I think that's what we're in a sense we're coming up with. But I think there's a general consensus here that somehow creating that local working together and local collaboration, maybe within a national framework, sure, if there needs to be that, but working together locally is the key to all this, because actually you will have different healthcare pressures and different pressure points and different issues in various regions, and clearly different providers with, as we alluded to earlier, different skill mixes and different specialities. So I think more decentralization of both operational activity, commercialization, and clinical pathways, for me, is the big learning point out of this. I think you're on mute, Alan.
Apologies. And Ian, from your perspective, again, some of these, I know we've kind of touched on these, but are there any other kind of really key learnings that we can take from this kind of NHS independent sector partnership that we've seen over the last 6 months, that I get that really need to be embedded, that we can embed within this kind of culture ultimately going forward, that will make a more harmonious and collaborative partnership going forward?
Yeah, I think there are. I agree with David's comments about, you know, obviously there has to be a rule book, but within that, and that's national, that's going to be set nationally. But within that, I do think that where effective partnerships are working, they do need to be given the space within which to continue to work, because otherwise we just become constrained by the bureaucracy, we become inefficient, and we just don't deliver things. So I think that's one thing. I also think that that, you know, it's about that collaboration. It's about sharing and being prepared to share without undermining people's commercial viability, clearly. But for example, you know, where we have a screening protocol that we've had to develop that internally in UHB, I've taken the choice to say, look, we will offer this out. We will share this around to our independent sector providers to look at. You know, it may or may not be something that they pick up and use. And we've shared it with other NHS providers. So rather than everybody having to write their own version of a document that ends up used within one system, we need to try to get to a place where we can share as much as possible our policies, our procedures, because that actually helps then in the engagement and the transfer of work between us, because it takes away some of the governance hurdles that otherwise get in the way. So I think those two things are quite critical, actually.
Thank you, Ian. So I think actually, I know that David has got to leave us at past. So I just wanted to, I thought this moment it might be a good chance for us to drop to a few questions that have been sent in from our attendees. So we do have a question from David Hewin, who is a surgeon. His question is: we're on the verge of a second wave of COVID admissions, as well as managing the direct effects of this. How will the NHS independent sector partnership deliver the necessary continuity of elective care during and after this second wave? So, I mean, I guess first and foremost, if I could pass this to you, again, back to you, Ian, if that's okay. I just wonder from your perspective, what you think needs to be done to continue this continuity from your kind of at the coalface experience at the moment.
So I think it's a good question. Obviously, within the confines of how much space we have, we need to be driving to use that as efficiently as possible. Within BSOL, we have now a model that will allow us to look at our capacity across the system, which we know is constrained, but it will allow us to actually do some scenario planning with regard to individual specialties and the profile of their waiting lists over time. So I would then think that having done that and looked at that, we then as a system need to be prepared to flex our capacity to meet those different specialties demands. So that will involve the independent sector, but that will also involve the NHS providers being prepared to do things differently. And we've been successful in that as well. So Royal Orthopaedic has helped us out tremendously with regard to some work that we just couldn't get done at UHB. So it's about, I think, identifying where there is growth in the higher category work and targeting the resource against delivering that. And we need to be flexible in terms of how we do that and expect that to change over the next 6 months to 12 months, however long the contract ends up being.
Thank you, Ian. And David, I guess from looking at that kind of wider view as a representative of the independent service providers, what's your thoughts on that, about how we retain this continuity for this next phase that we're inevitably moving into?
Yeah, it's a good question. Thanks, Alan. Now, the reason I have to stop at 10:30 is to actually discuss the next phase of the contract. So I think the key thing here is going to be a national decision about capacity. And obviously, if we do end up with a COVID peak that is so sizable that it takes the full resources of the health system to tackle it, then no policy in the world is going to enable continuity of elective care. So I think we are reliant in that sense on the current restrictions on social interaction actually having that effect, or we will face something that I think will be very, very difficult for all of us in different ways. However, I think we certainly share and understand the determination at every level from the Prime Minister on down that what we cannot do again is kind of suspend the normal business of the health system in the way that we had to back in March, April and May. And I think it's really important to say you know, lots of urgent treatment continued. Patients have still been able to get access to treatment, but we have to be honest about the disruption it caused, and it did, you know, and we're dealing with that backlog now. And I think if we have to do that again, we're going to be in a very, very difficult place for a very long time, and those numbers will get out of control very quickly. So I think we are all working extremely hard to make sure that we've got that capacity in place and that it can be used for the kind of normal business of the health system alongside the COVID response. And of course, we will do the COVID response better this time around, because we've learned a lot from what happened the first time. So I think there's that to hold on to as well.
Thank you so much, David. And again, over to you, Tony. Obviously, as the head of a provider yourselves, I mean, what are your thought processes about how your business responds as you move into this next phase?
So I think there's some really important points there that were made, and the question really is a good one about continuity of care. And I think you're right. I don't think we can move into a place where everything was suspended like it was previously, because if we're saying that takes us to a place where it will take us many years to recover, well, I think actually it will take us a number of years to recover, with 10 million on the waiting list, and that probably being understated. If that's the case, I think we're already there in that respect. So we can't anticipate that issue. And I guess from a very parochial provider's point of view, as good as our strong as the relationships were at a local level, and they were, and still remain so, actually our capacity was underutilized during this period for whatever reason, and I think that's true of a number of independent providers, where our capacity wasn't utilized to the full. Now we're all learning on the job, if you like, very quickly repurposing facilities, very quickly getting into arrangements that we hadn't got into before, but we had more capacity to do. And I guess coming back to David's point about ensuring that the capacity is available, I think the capacity is available to deal with these backlogs, but it's got to be used effectively. And for me, that comes back to the central point. I sound like a bit like a broken record, of the ability at a local level to take more decision making around how arrangements with independent providers are purposed. And
I guess just expanding on that, Tony, and I think there's another question that we've come in that I guess aimed specifically at yourself as a provider. You know, for a company like yourself who are new to delivering NHS services, you know, will you continue to deliver NHS services, or will you revert back to the kind of private elective cosmetic and bariatric surgery?
Well, that's our core business, is that, and we're not going to abandon our core business, of course, but we are working hard at finding ways to manage the NHS activity alongside our core activity. It's absolutely what we want to be doing, because I think it's opened our eyes to the value of being, you know, providing broader range of healthcare services, which is, as I said before, was a sort of a journey we were on anyway, commercially as a business, but actually to do that and provide it in the circumstances we did for the NHS, there was a lot of good came out of that for the business generally, and our skill sets and the feel good factor within the business and so on. And we'd like to continue doing that for sure. That's absolutely the intention. Yeah.
Thank you. I mean, I just wanted to. I know we were looking at some of the questions from our attendees, but there was another question that I wanted to ask, which was about public perception actually, and it was about what more needs to be done to change public perception towards the independent sector, and I guess ensure it's embraced as a positive force for change. Now I know David's not is having to leave, or certainly will leave us any moment. But I wonder if I could just put this across to you, Ian, actually, as obviously as a senior NHS professional, and you know, we've talked about there was talk in the introduction about, you know, we need to get away from this, and I know Tony said this kind of public good, private bad. And I just wondered whether we could get your thoughts on that, Ian, really, about what could be done, how, you know, what's the way forward to try and, you know, from a hearts and minds perspective, fundamentally, to try and make this collaboration perhaps work better, not just physically, but also, I guess, from a perception perspective with the general public.
Yeah, I think that's a very interesting challenge, actually, and it was quite interesting in the early days of having to reconfigure our services internally and externally, that a number of patients were offered an alternative site for their surgery. And, you know, initially in some specialties, we had 30–40% of patients were saying, no, thanks, I'll wait till after COVID and I'll come back to the hospital that I know. So it gets really complicated because, to my mind, there was no good reason for those decisions. You know, I was confident that we were moving from one site to another site with equally good governance and safety and outcomes to be expected. And it made no sense to me that patients would say, well, no, thanks, I'll just wait. Now, of course, that's about comms, it's about managing anxiety, it's about the perception thing. And we've worked really hard as a system, I think, to try to do that, to support patients in their decision-making, both directly and through their primary care advocates. But there is much more to do. And I think I would agree that it is also an important part of the cultural change around how we make independent sector providers feel like they are more part of the system. And I think that's the answer, is that it is about building on the good work we've done, making sure we have consistency in terms of how we approach the management of patients. Because at the end of the day, it's the same doctors, you know, it's the same surgeons going out to do your operation. So sometimes that conversation actually makes it fine. But there is still an issue, I agree. And I think it's about alignment of our governance structures and being clear with the message that it is a system now. It's not the NHS and a few other people over there. We are working together for a very good reason to do more than we would otherwise be able to do. And I think it's about comms, repeated comms that are saying exactly that.
Thank you. And Tony, again, you know, clearly this is, you know, a subject that's you know, fundamental ultimately to the kind of future integration of the kind of the independent providers into this system that we've talked about this morning, you know, this overall system. So, I mean, where do you sit on this, Tony, in terms of, you know, how can we change, you know, what needs to be done to really change perception of this kind of public? And I know this was a really key point you made at the very beginning of your introductory statement.
Yeah, actually, I think it's less of an issue. I'm surprised actually and that's made me pause for thought by Ian's remark there about the patients saying, no, I don't want to move. I'll stay with the hospital I'm comfortable with. Whether that is to do with private bed or whether that's to do with familiarity with that hospital, I'm not so sure, because I get the sense. And I think there's some research actually that IHPN did, so shame David's not on the line anymore, that suggested that the public at large were less concerned actually about their eventual provider of care, providing it was, you know, a good quality, good governance, delivered free at the point of use and so on. They were less concerned whether that was in a private or in independent or public setting. So my comment about that was perhaps one more the industry and the politics around this rather than the general public. But I suspect there's still some work to do with the general public. And yeah, I come back to Ian. It's about you know, it's a whole systems approach. It's not just, you know, us here and them there, and we're all integrated, and it's comms. That's the thing. And ultimately, good communication and information about data and information about outcomes and so on and so forth will change that perception where it exists. But I think it's less of a problem actually with the general public than it is with the institution, if you like, of healthcare and the politics around it.
And I guess, so I would kind of lead that back to Ian then, if you would, because I think, I mean, one of the questions I wanted to ask, I guess, as we just kind of move towards the end of this, I guess it's about optimism fundamentally. It's about optimism about where the direction of travel of this partnership, which has clearly been a success for the last 6 months, you know, under, you know, tackling this common enemy as you described. And I think that, you know, that kind of captures it perfectly. But it's really, and Tony's just mentioned there about maybe it is less about the public and more about the institutions, and maybe these are, you know, even though as you suggest, a lot of the people who are doing the private health provision individually are also working in the public sector as well. But I guess it's about optimism, Ian. I mean, where do you sit in terms of how you see this going forward? What's your, your real instinct in terms of how you think this will develop?
Well,
I know that's sorry.
I mean, yeah. Hang on, Alan. I'll just get my crystal ball out.
I know that.
I think there's no doubt in my mind, having, as I said, having had almost no interaction with independent sector colleagues prior to the start of this year, other than through difficult contractual, we want to do something, but it's just too hard. To have got where we've got to is really, I think, a very big success, and we have to keep some of that. So yes, I am optimistic that we can do more. I'm also optimistic that we can do more. I mean, I don't know if there's anybody from HCA on the call, but we are building a joint facility from UHB with HCA. So clearly that partnership working between the NHS and independent healthcare providers is now something that will have to, quite rightly, continue. What exactly that form takes, I think, will vary depending on locality, and also critically depending on, sorry to go back to it, but depending on who is paying for it. Because ultimately, at the moment, I don't see a way in which our local CCG or my trust have got the pockets that are deep enough to pick out the cash to pay the kind of sums that would be required. We're being asked to do everything that we're doing for COVID, everything that we're doing for emergency care, and our normal elective programme. Now, that is actually not deliverable within the NHS. I would say that, and I'm happy to defend that to anybody that asks the question. But we will try really hard to do as much as we can. But that doesn't help us in terms of the backlog. So if we are then having to deliver more in terms of backlog work, the independent sector has an obvious role in doing that, but that comes at a cost. And somebody somewhere has to work out a way of financing that. And then I think we can make it work very effectively.
And Tony, from yourself, again, I don't ask you to have a crystal ball either, but what's your instinct on how this will evolve over the coming weeks, months, and years ultimately?
Well, I share Ian's optimism. Ultimately, I'm generally optimistic sort of demeanour anyway, and person. But I think the shock of COVID and what that galvanised everyone into doing, I don't think, like in many things actually, I don't think we'll come back from that. I think we've got to a place where we've seen the benefits of collaboration, and lots more to be done to sort that out. And ultimately, as Ian says, the commercial realities don't go away. In fact, they come more to the fore when there's not an open checkbook here. But actually, I'm very optimistic that we have got to a position, that's been pushed into a position clearly, where there is much more collaboration between the private sector and the public sector and a more of a whole systems approach to healthcare. And I think we'll build on that, and it's the responsibility of all of us in healthcare, and we play quite a small part in that, but all of us to build on that. And it would be we've been neglecting our responsibilities if we didn't try and build on that. So I'm quite optimistic we will.
Fantastic. Well, I think we've covered quite a lot of ground this morning. I don't know if there were any further points that you felt you would like to cover. I know that it feels like we've given it a good debate today, and so I think it leaves it for me really just to say, thank you ever so much to all our attendees for visiting. But most importantly, thank you, Ian. Thank you, Tony, for joining us this morning. Thank you, David, who again had to go this morning. Wishing you all, the very best of luck going forward. We hope that this, that a lot of the positivity that we've discussed today, kind of becomes a reality as we move over this second phase. And like I say, it just leaves it to me to say thank you everybody for being involved today, and I hope everybody's found it really useful.